So I think we can start the next session that will be moderated by our dear friend from Italy, Mario Preti. Mario is one of the most hardworking prevention committee members. He produces a lot of projects, and you can always feel free to contact with him in different projects. So, Maria, let's start the next session with you, the colposcopy.
Well, thanks. It's a pleasure to moderate this session among friends. And so I think we can start with the presentation of Mihaela Grigore, which is professor of obstetric and gynecology at the Grigore Poppa University of Iași. She specialized in minimally invasive surgery and cervical pathology. She is currently the secretary of the Romanian Society of Colposcopy and Inferior Lower Genital Tract. She is member of the advisory board of the European Federation of Colposcopy, but most of all, she is member of the prevention committee of the ESCO. So the stage is yours, dear Mihaela, and normal colposcopy setting and findings with particular focus on Africa. I close my camera and microphone, and it's up to you.
Hello. Thank you very much for invitation. Congratulations, Murat, for this conference. I think the number of participants is amazing. I will start this colposcopy session by discussing the normal colposcopic findings. And first of all, I would like to remind you that during colposcopy, we have several important steps. And these steps are represented first by the saline solution. We apply saline solution in order to inspect the surface, and only with this step we can see some abnormalities. Then we apply acetic acid, and the effect of acetic acid will be coagulation of the nuclear proteins. So the higher is the amount of the nuclear proteins, the most intense the white color will appear. And last, we apply the Lugol solution, and the epithelium will stain brown because of the glycogen which is inside of the epithelium. Another important thing to remind is that on the cervix, we have two types of epithelium. We have the squamous epithelium, which is a multi-layered epithelium. And also we have a columnar epithelium, which is a single-layered epithelium. And also in this columnar epithelium, there are the so-called reserve cells, which we will see later. They are very important. How is the aspect of these two types of epithelium in colposcopy? So we will start with squamous epithelium, which I told you it is a multi-layered epithelium. It will appear pinky because of the subepithelial capillaries. Here also we have an example how it looked like the squamous epithelial before acetic acid. In the middle, after acetic acid, we see it is pink. And after we apply the Lugol solution, this squamous epithelial will become brown. During menopause, the things can be a little bit different because in this period, the epithelium is thin and the capillaries, the vessels which are in the stroma are less represented. So the color will be not pink, will be pale. And also after we apply the Lugol solution, we will have a yellow color, not a brown, because the amount of glycogen is decreased in this period. What about columnar epithelium? Well, the columnar epithelium is quite easily to identify and to see it because of the so-called grape-like appearance after we apply acetic acid. You see here the image after applying acetic acid. And very important is the limit between these two types of epithelium, the squamous and the columnar epithelium. This is called the squamocolumnar junction. And the ideal situation is when this squamous columnar junction is on the ectocervix, because we can see it. And why it is important to see it? Because in this area, the abnormal process will start. This ideal situation is usually during the reproductive life because of the hormonal changes. And because of these hormonal changes, the cervix suffer the process of eversions, and the ectopic epithelium will be on the ectocervix, like we see here in this picture. But the situation will not stay like this, because a process of metaplasia will appear. And what is this process of metaplasia? This columnar epithelium will be replaced by squamous epithelium. And this process has some stages, actually 3 stages. The first one will be a hyperplasia of the reserve cell. Remember, I told you that in the single layer columnar epithelium, we have some cells called reserve cells. So this reserve cell will become hyperplasic. Then immature metaplasia will appear, and then the process will finish by the mature metaplasia. Of course, in colposcopy, we have some specific images for these stages of the process of squamous metaplasia. First, we will see a loss of translucency of the villi, then the villi will fuse, and finally the villus configuration will be lost and a new surface will appear. Why is important to understand this process of metaplasia? Because of this process of metaplasia, a new squamocolumnar junction will appear. And why is important? Again, because between this new squamocolumnar junction and between the original squamocolumnar junction, we will have the transformation zone. And this is a very important area, because in this area, the abnormal process will appear. So if we want to see if we have an abnormal area in the surface, it is very important to identify and to see the entire transformation zone. So again, this zone is the area between the original squamocolumnar junction and the new squamocolumnar junction. And we have here some examples of this transformation zone. We have picture images before applying acetic acid and after we apply acetic acid. And we see here how it looks like this transformation zone. We have some tips, let's say, how we identify the transformation zone. And one of them is that in this transformation zone, we see the Nabotian cysts. What are these Nabotian cysts? These are mucus-filled cysts on the cervix, on the surface of the cervix, and they can be small, like here in this image, these white yellow dots. They can be small or they can be large, like in this picture. And in some cases, maybe the vessels on the cyst can look worry, but if you look, these vessels are actually normal. They are branching in a normal way. Another way to identify the transformation zone, there are the crypt openings, as we see here in the image. They appear as dots surrounded by a thin aceto-white rim located in the transformation zone. According to the last classification of the IFCPC, we have 3 types of transformation zone. The type 1, the ideal situation, is when the transformation zone is completely on the ectocervix, so we can see it clearly, and we can see the squamocolumnar junction on its entire length. The other one is type 2, when the transformation zone has an endocervical component, but the squamocolumnar junction is fully visible and any ectocervical part of the lesion is small. And the last type is type 3, when the transformation zone has an endocervical component, and unfortunately the squamocolumnar junction is not fully visible. We can see it, but not fully visible. So in the ectocervix, we will have a part of transformation zone and we cannot see. And why is important to say that it is or not a transformation zone type 3? Because in type 3, because we do not see entire transformation zone, it is possible to miss or to not see some abnormal area. And let's see some example. For example, here we have a transformation zone type 1. We have the image before and after acetic acid. We clearly see here the new squamocolumnar junction, and here, I hope you see my pointer, and here you see the original squamocolumnar junction. So this area is the transformation zone. So if we are looking after an abnormal area, here we must look and inspect very careful. Here is another example of a transformation zone type 1, the image before acetic acid. We see this red area. This is the transformation zone, and we clearly see after we apply acetic acid, because we now see the new squamocolumnar junction. We see that is here probably the original squamocolumnar junction. I need to mention that sometimes it's difficult to see the original squamocolumnar junction, the entire original squamocolumnar junction, but because of the gland opening, the crypt opening, because of the Nebotian cyst, we can guess where it was this original squamocolumnar junction. This is an example of type 2 transformation zone, and look, both images are after we applied acetic acid. And while in this image in the left, we see the new squamocolumnar junction, but not in, we don't see completely. But here in the right, we use a swab, and using this swab, we can see in the endocervical canal. And using this swab, actually now we can see the entire squamocolumnar junction, the new squamocolumnar junction. So we can say that we have here a type 2 transformation zone. And here is an example of the type 2 transformation zone. We do not see, and we have image after applying acetic acid. Unfortunately, we do not see, not at all, the squamocolumnar junction. So we assume that this junction is inside of the endocervical canal. And in the right part, we see the image after we apply Schiller solution. So this is a typical case of a type 3 transformation zone. And usually we find this type of transformation zone during menopause or after procedure on the cervix. After conization, for example, we can have this type 3 transformation zone. I would like also to mention that during pregnancy, we have some specific aspects. And in this period, the cervix is large, it is soft, it is congested, and it is covered with mucus. So the colposcopic examination could be sometimes a little bit difficult. Also, the epithelium is blue colored, dusky blue, because of the underlying vascularity. And also the squamocolumnar junction is easily visualized because during pregnancy, the squamocolumnar junction is everted. So from this point of view, it is easily to see the entire transformation zone. But otherwise, we have, as I said, some difficulties in examining the cervix. And also during pregnancy, the blood vessels are prominent, and if you are not very familiar with the images during pregnancy, they could look a little bit abnormal, but actually they are normal. I would like to say also that sometimes during pregnancy, we have the images of deciduosis, and we have here some picture of Professor Vesna Kesic, and we thank her for these images. What is deciduosis? There are some stromal changes with focal decidual changes, and this can sometimes embrace this form of a polypoid protrusion of the cervical stroma. This is quite a challenging situation, both for colposcopists and both for pathologists. And if we are not sure, it is not a bad idea to make a biopsy and to advise the pathologist that it is a pregnancy and that is possible to have a deciduosis. And last, I would like to remind you another normal image, the so-called congenital metaplasia. What is this congenital metaplasia? It is the metaplastic changes which result in a permanent aceto-white epithelium. And in this white epithelium, we can find a fine mosaic. Usually this epithelium, this white epithelium with mosaic, with fine mosaic inside, extend as we see here on the anterior, on the posterior wall of the vagina. And if we are not advised of this situation, we can misconfound, we can interpret as an abnormal low-grade lesion, but actually it is a congenital metaplasia, so it is considered a normal image. Thank you very much for your attention.
Thank you, dear Mihaela. Of course, we thank you for the importance of the normal aspect of the cervix, because if we don't know what is normal, we cannot understand what is abnormal. Thank you again. And the next speaker for indeed the abnormal colposcopic findings is Professor Vesna Kesic from the University of Belgrade. She's a full professor from 2020 and 12, and now she is professor emeritus. She's an ESGO past president, and he's one of the leading specialists in gynecological oncology, not only in her country, but in all the Europe. And so we are ready to listen to your presentation, dear Vesna, about the abnormal colposcopic finding, grading, and terminology. Thanks.
Thank you, dear Mario. I would like to start the presentation.
Please try to click into the screen, and you should be able to.
I tried. Yeah, I'm clicking into the screen. Okay, so now we are here. Thank you, thank you. Hello, dear colleagues and friends, colposcopy lovers. Special thanks to the organizers for the time and effort they made to organize such an outstanding event. Due to the limited time for my presentation, I will go straight to the target: abnormal colposcopic findings. You have just heard an excellent presentation of Professor Mihaela Grigore, who mentioned squamous epithelium, glandular epithelium, and squamo-columnar junction. I wish I didn't make these animations, because could you help me? It doesn't go now.
Yes.
Yeah, I'm clicking, but nothing happens. Okay, it will be slow, I guess. So this is not bad, because it will force me to speak slowly. So this line is marking original squamo-columnar junction. The other one,
please try to click into the screen once again.
yes.
Yes, you are
Yeah,
controlling
this
the
is original
presentation.
squamocolumnar junction. This is new squamocolumnar junction. Maybe I should click by mouse, not by on the keyboard. Let's see. I hope this will work. So the area between these junctions, originally new, is called transformation zone. Transformation zone is a very important area for us. And in colposcopy, it is essential to assess whether it is normal or abnormal. Then to exclude the invasive disease. And finally, if we find something, to differentiate between low and high-grade squamous intraepithelial lesions. We use colposcopic terminology, which divides all findings into 4 main categories: normal findings, abnormal, suspicious for invasion, and miscellaneous findings. The development of abnormal pictures is the result of immature physiological metaplasia. It can be very confusing sometimes, but most often the abnormal pictures are caused by human papillomavirus infection, CIN, or invasive cancer. There are several abnormal colposcopic findings, several types of lesions. We call them leukoplakia, acido-white epithelium, punctations, mosaic, atypical vessels, and finally iodine negativity. They are in the terminology IFCPC you have just seen. What is leukoplakia? It is white plaque visible without magnification and very important before the application of acetic acid. If you don't see something before the acetic acid and it appears white later, it's not leukoplakia. We see it before we put acetic acid, and it is not necessarily limited to the transformation zone. It is usually elevated a little bit from surrounding surfaces with sharp borders and Lugol staining, as you can see on these 2 pictures, 2 very nicely visible, well-defined leukoplakias. The other is acido-white epithelium. It is something that appears white after the application of acetic acid, and it is not specific. It represents epithelium with increased nuclear density. It is not necessarily dysplasia. It may be reparative changes, inflammatory changes, irritation. So keep in mind that acido-white epithelium, as well as leukoplakia, is not specific. Punctations. What are punctations? They are colposcopic findings reflecting capillaries in the stromal papilla that are seen end on. They penetrate the epithelium because they must feed, nourish the abnormal epithelium. You understand the process of normal metaplasia. In normal metaplasia, all the vessels would be diminished and situated after the metaplasia below the epithelium. Here, in abnormality, we need vessels, and in punctations, we see them as red spots on basically white area. Something similar is with mosaic. Mosaic are the islands of squamous epithelium, also abnormal epithelium, but now they are encircled. The blocks of abnormal epithelium are encircled by blood vessels. This is some they call basket-like arrangement, and from looking from above, we see them as real mosaic. We don't know why sometimes mosaic and the other time punctations will appear, but they both may be the result of inflammation of rapidly growing metaplastic epithelium, CIN cancer, and specifically punctations are seen in recurrence of cervical cancer. This is the most typical picture of recurrence in punctations. Iodine negativity, you have just seen some examples. atrophic epithelium, immature metaplasia. Why immature metaplasia is not staining? Because it still, this epithelium, metaplastic immature, still doesn't contain glycogen. In atrophic epithelium, postmenopausal epithelium, there are not, it is atrophic epithelium, they are not estrogens. So no glycogen as a result, and the staining is very pale. But also we keep in mind that all these hyperparakeratosis, clinically seen as leukoplakia, cervical intraepithelial neoplasia, may appear as non-stained area. Atypical vessels are probably the most difficult for us in colposcopy. It is not easy to say or to recognize whether abnormality belongs or neoplasia or maybe is part of some other process. They are irregular. They appear on the surface and then suddenly disappear. They have an interrupted course, look as coma, corkscrew capillaries, spaghetti-like forms. There are different forms which are definitely not reminding as a tree-branching normal vessel, which we see in normal epithelium. Atypical blood vessels have always been the hallmark of invasion, and when we were young, we were taught to take the biopsy for any atypical blood vessels. It is true that they are seen in pig cancer and cancer, but we must keep in mind that they can appear in inflammation, like here. This is just a severe cervicitis. Post-irradiation, you all know the effects of irradiation in terms of neovascularization. Rapidly growing metaplastic. This is rapid metaplasia, normal, immature. But see these vessels, it's like really to get scared of them, and they are basically nothing. We should keep in mind systemic diseases such as diabetes, hypertension. These women can also have abnormal vessels. So if we find abnormal lesion, what we need to do? To define the limits, to decide about the grade, and to select the most severe area. The first question is the lesion fully visible? There is a big difference in the case where we see the lesion fully and can judge about its severity. In this case, where the upper part, the upper border of the lesion is in the endocervical canal. Endocervical canal is probably the greatest limitation in colposcopy. So we shall never be able, by colposcopy, to be sure how high and how difficult the lesion in the canal is. Then we can, looking this way, we divide transformation zones, as you heard also, to type 1, 3, and 2. Type 3, all these situations where the squamocolumnar junction or the lesion is not visible require very much attention, because they can be CIN3, see, as in this lesion, they can be microinvasive cancer. Would you say, just judging according to the outer finding, that there is something so bad inside? It was microinvasive cancer, and here it was even invasive cancer. So keep in mind always transformation zone type 3. When we see the abnormality, we must do grading. We must try to predict the severity of the lesion, and we do it based on the color tone and opacity, margins with normal tissue, surface pattern, vascular pattern, iodine staining, and lesion size. Let's try to go step by step. First, the color. When we put acetic acid, severe abnormalities are intensively white, and they become white faster. You can see the difference between these two lesions. This lesion is severe, and this is a much, much less severe lesion, low-grade lesion, which will appear very slowly, disappear immediately, while severe lesions will retain color longer than less severe lesions. Surface. The more irregular and more elevated is the surface, the lesion is more severe. Again, the examples. This is a large lesion, I would say. It is a low grade, but the surface is very smooth compared to this one, which is similar in size, but with completely different surface. This was congenital transformation zone we just mentioned, and the other was CIN3 high-grade cervical lesion. Borders. In high-grade lesions, there is always clear demarcation, defined demarcation zone between normal epithelium and the lesion, while low-grade lesions have less defined borders, which we call sometimes geographical. They are not linear. And this is also one of the components which can help us to make distinction. Intercapillary distance, it is the distance between vessels if we see them and when we see them, but also the size of mosaic field, the size of punctation. We also considered capillary network. You have just seen why, because these are the red lines around the mosaic fields, and the red spots are the vessels. So the increasing lesion between the vessels, the larger mosaic field, the bigger punctations, they are indicating the high-grade lesion. As the lesion is becoming more severe, that distance increases, and the bigger the vessels are and further apart, the lesion is more severe. You have here example, the same place, the same size, but the same type. This is mosaic type of abnormal finding, but this is low-grade lesion, and this was high-grade lesion. And now when you know all these features that I mentioned, you will definitely be able to get impression if somebody shows you these pictures, where is low-grade lesion and where is high-grade lesion. Yoda and staining for years haven't been counted into terminology, and in our last terminology, IFCPC terminology, it is included as one of the features for grading the lesion. Low-grade lesions, iodine staining may be brown, as in normal. It may be faintly or patchy yellow, like in low-grade lesion, or maybe very well seen, very clear and distinct yellow as in high-grade lesions. Finally, the terminology counts lesion size, and it is a big difference whether the lesion is small in one quadrant or it occupies the 4 quadrants. But I put these pictures just to warn you that high-grade lesions are not necessarily that big. This was high-grade cervical lesion, CIN3. But believe it or not, this was also CIN3, although it on the first sight looked as a small, simple condyloma. Ideally, we should grade or score findings as normal, low-grade, high-grade, and suspected cancer. Today, European Federation for Colposcopy is using something we call Swedish score. This is just one of the scores, taking into the account all these features we just mentioned. There were different scores, and it may help to the beginners to give points to acid uptake, 0, 1, or 3, margins, vessels, lesion style, staining, then counting adding these points, we can say, is it like low-grade lesion, or maybe like high-grade lesion or invasion? Remember, colposcopy is not histology diagnostic, so we can be happy if we can predict the severity of the lesion, but we can never say that it is diagnostic lesion. It serves just to decide what we are going to do. Just to summarize, we have low-grade lesions. The lesions of concern for us are low-grade lesions, minor changes. Low-grade lesions, I shall summarize, they usually have smooth surface with an irregular outer border. So you see that all features are combined into this description. This is very slight, very pale acido-white change, which slowly appears and quickly disappears. So you must sometimes add another acetic acid to get the lesion back to be visible. And iodine positivity is usually partial and not distinct yellow or oyster yellow. If we have punctations or mosaic, they are very fine, small, and regular. To the contrary, colposcopic features suggestive of high-grade disease. In colposcopy, we divide them only to these two categories, G1, low-grade, minor changes, and G2, major changes. So we follow somehow the last terminology. Major changes have generally smooth surface, sharp outer border. It is very white, dense aceto-white change, maybe sometimes oyster-white. It appears early, immediately, and it resolves slowly. Even without colposcope, if something is very bad, if you look by your eye through the colposcope and put acetic acid, you will see that dense aceto-white change. Punctations or mosaic are coarse, irregular, and iodine negativity is present. Another question is coming now: when and where to take the biopsy? This will be the presentation of our dear teacher and friend, Professor Mario Preti. Before I finish, I just have one message. Everyone can look through the colposcope, remember, but only good colposcopists, only the one who likes colposcopy would know what he is going to see. Our primary goal is to ensure that invasive disease is not missed. So we are all together. We enjoy working together. This event was one of our meetings, and we are happy to share our knowledge. This is why I will just mention the meeting in my town in Belgrade in September, where we shall talk again about the same questions. It is anal genital disease in focus. So join us. Thank you very much for patience.
Thank you, dear Vesna. Thank you for your wise words and great lesson. Thank you. Well, it's my turn to present when should a biopsy should be performed, and I thanks the organization. That's fine. I click here. I am from the University of Torino. I deal with cervical cancer screening for more than 30 years, so old man. Well, I click here. Okay. Of course, just few words, because most of the following slides are already been presented by the previous speaker, and in particular from Professor De San Jose and Professor Didem Egemen. And so we know when and where the cervical cancer strike harder. And we know the risk factor for progression from infection to the lesion. And in sub-Saharan Africa, we have the HIV infection that increase the progression from infection to cancer. So we have to take into consideration, beside the HPV genotype, the persistence of the same genotype, small co-infection, this type of immunodepression. And so when we deal with colposcopy, that we know that is the cornerstone of the management, and biopsy can be modified depending on the risk of precancer, we know that sometimes we have no HPV vaccination and we have no screening history of the patient. So the theater can be quite different. So from the unalterated screening test in high-income countries, we have to deal with treatment in low-income country, where the gross per capita is very low. And we come back soon here because we have to take in consideration if we have to biopsy or not to biopsy. Where to biopsy, we have seen from Professor Kesic the G2 high suspicion for high-grade lesion. But how many biopsy to take? And then the cervical curettage and treatment without biopsies? So let's start from the beginning. We know that practitioner with less experience take more biopsy, and taking more biopsy, they reach almost the same sensitivity of practitioner with more experience, but more biopsies means more money to invest. So probably more experience and less biopsies. And we have seen that no more than 2 or 3 biopsies are needed because the total yield for respective number of biopsy is stopped at 3. No more yield for increasing the number of biopsy. And these data are the first step to consider the efficacy on the population on standardized protocol for colposcopy and biopsy. And then the number of biopsy depend on the risk of the patient. Most of all, the age, the clinical history, the HPV genotyping, and of course, cytology and colposcopic grading. With a single test result, we have no so performing the risk stratification. More tests we have, more better is the risk stratification of the patient. And of course, in high-income countries, we also have lesson on random biopsy. But if we see the yield of random biopsy when a negative colposcopy is present, then probably is needed more training for these colposcopies. As Vesna just told us, one man, one woman looking through a colposcope doesn't mean a colposcopy. So it's important the training. And then the cervical curettage, yes or not? We notice from the American Society guideline that is recommended when the squamocolonial junction is not fully visualized and preferred in patients older than 40 years, and also recommended for patients with HPV 16 and 18 positive test. But we know that the yield of endocervical curettage rises with the age as the squamocolonial junction retrocede in the endocervical, where the lesion may arise and progress undetected. But in age, older patient, higher grade of cytology, HPV 16 and 18, and higher grade of the colposcopic lesion, we have the higher yield of endocervical curettage. So these are, for the most part, beside the colposcopic impression, all tests that we have before the colposcopy. It is important. And so, given this information, which is the best approach in Africa? We heard about this risk stratification, but we can change the title of our presentation, not when a biopsy should be performed, but should a biopsy be performed? Probably looking at the incidence of cervical cancer and taking into consideration that most than 60% of incident cases die for invasive cancer with respect with higher income countries, probably we have to change our approach when we see that most of the cases are late stage diagnosis, in particular in these darker countries. What are the main problems? We heard from Professor Omar Gazama that the high cost, the limited healthcare infrastructure for laboratory screening tests, the transportation and electricity constraint, the limited number of specialists. From this paper, we learned that risk-based management for cervical cancer prevention follows 3 steps. Identify the risk factor, estimate the risk associated with those factors, and manage individual based on their estimated risk level. And of course, as Professor Egeman already showed you, when we have high resource setting, we can better stratify the risk. And in this setting, multiple triage tests are employed to avoid overtreatment, and many screening participants are assigned to long-term surveillance with frequent repeat tests. Changing the risk based management in low-income countries, we can say that risk-based screening should focus triage and treatment resource on the highest risk patient while minimizing intervention in the lower risk group patient to reduce the incidence and the mortality from cervical cancer. So we have higher risk patient and refer for excisional or ablative treatment, and with lower risk, estimated risk, no treatment and follow-up if available. Of course, at the moment, HPV tests result and remain as the primary risk stratifier. We just give a look quickly to this paper that Professor Egeman already presented, not only from this paper of 2 years ago, but with most updated result, how important is the HPV in classified with the AVE classification, the risk of the patient, and probably in the future when the validated methylated DNA markers will be available, probably HPV DNA test with methylated DNA marker can better stratify the risk and allow us to perform treatment only in selected group of patients. We see the portable device in the previous lesson, very important. So alternated screening tests lead to colposcopy and treatment. Does it work? Yes, it works. We see from rural India when patients submitted to colposcopy were offered to immediate cryotherapy and reduced the incidence of later stage of cervical cancer and reduced the cumulative mortality of cervical cancer. And the same happened in Nigeria with self-sample collected and the management according to the HPV positive women and the colposcopic impression. Coming back to Italy, we can learn that attempts should be made to increase the detection of high-grade CIN with standardized training program, and the training program are important in Europe, USA, and in Africa, in all the countries. The training program that is mean, in particular in this paper, is reported that with this procedure, for example, low-cost universal cancer institutional apparatus with these other aceto-white changes that appear when hot water is applied, and to teach how ablative of excisional therapy could be performed. So the trainer model to be sustainable and train proficiency colposcopy and local training at the same time to reduce the cost of moving people to the training sites. Well, our conclusion, saving 5 minutes from our lecture, is to identify very high risk population, less specimen. We have no money for a large amount of specimen, but more technology and focus on education and training. Well, question for another time. Now, I take a couple of minutes to allow the technician to fix some problem, and I would like to ask Professor Vesna Kesic and Professor Grigore, how can they apply the wonderful lesson in the African continent? Because we know that even in Europe, the colposcopy has a low reproducibility. So please, Vesna and Mihaela, tell us some wise words. Thank you.
I'm not sure what to say because colposcopy is as it is. And interestingly, I think it is one of the very few methods that didn't suffer any change from the time it was developed. There were so few changes in the equipment, in the technique of colposcopy. So maybe new technologies, these small colposcopes, the hand colposcopes, and consultation online, sending the pictures. Maybe I see this as a potential solution in the places where there is no colposcopy. But if you speak about colposcopy, it is either you have it or not. The places where they have colposcopy, they should have knowledge and dedication for it. So I don't think there is some good answer. Mihaela, what do you think?
Well, I think that knowledge is important, no matter that if you are in Europe or you are in Africa or America. I think that it is important that you are familiar with the colposcopic images, with normal one and with abnormal one. And luckily now, due to internet, due to a lot of resources, we can train ourselves. So it's much easier now to be trained in colposcopy. There are a lot of workshops, a lot of online courses. So it's not difficult to get images. So the more you see, the more images you see, the more knowledge you'll have. So I think that all you need is to want to be good in colposcopy, and if you want, it's not impossible today. Previously, let's say 20, 30 years ago, it was clearly more difficult because we didn't have so many resources, but now we have. So it's just a matter to do it. It's just like this.
Thank you, dear friend. And probably should be the colposcopist to teach to the artificial intelligence to how to interpret the images. Thank you again. Well, now the stage is for Professor Patrick Petignac. He is the head of the Surgical Oncology Unit and the head of the Gynecological Division at the University Hospital of Geneva, Switzerland. He has international experience in cervical cancer prevention, providing the education and training in low and medium resource country. Thank you again, Patrick.
Okay, thank you, Mario, for the kind introduction. Okay, now I will not speak about colposcopy, but a smartphone-based image from the cervix. And the aim of my talk is to present this is our experience and possibility to have a photo from the cervix if you don't have colposcope. Okay, I have no conflict of interest. Okay, as you see on this map, the global distribution of cervical cancer is mainly in the South country, and especially in sub-Saharan Africa. And as you see on this map, yes, this is the burden of the disease is essentially in this area. Now I will report, this is our experience that we have in Cameroon. This is a partnership that we have now since more than 20 years. And this is our experience with cervical cancer screening, HPV testing, and smartphone experience. The success of cervical cancer screening in high-income countries, because we have cytology, now we have HPV, we have cytology triage, we have colposcopy, we have histology, and for women having a positive result, we have the possibility to do a conization and a treatment. But this is true for high-income country. We have all of this. We have cytology, we have HPV, we have colposcopy, we have histology, and we have thermal ablation, but we don't use a lot, but conization, yes. But in the LMIC context, you don't have all of this. Okay, you have in some academic center, but most of the time you don't have cytology, you don't have colposcopy, you don't have histology, you don't have possibility to have a result of biopsy. You have, but it's difficult. You don't have in district hospital and rural area. And the time in high income country, normally from the screening test until the treatment, it depends approximately 1 month or 1 month and 2 weeks approximately. But in low income countries, you have to do this in 1 day, maybe 2 days. But ideally, it's a screen and treat approach. This is what the WHO recommend. And the WHO now recommend a high performance test. Before it recommends the VIA, but the performance of the VIA, as we see before, is very difficult to have a quality control, and there is a very large difference between observer. And with the HPV tests, HPV is excellent test and very easy to do the test now with a new machine. And you have the possibility to do HPV test and treat. This is one of the recommendations of the WHO. Or the other possibility is to do a HPV test followed by a VIA triage. Because one of the problems, if you treat all HPV positive women, you will have a lot of over treatment. And using the VIA and triaging women being HPV positive, you reduce the over treatment. And of course, you do the self-sampling. As you know, if you do HPV testing, you have the possibility to use self-sampling. It is generally well accepted by the woman. And the performance of the HPV self-sampling is the same as clinician sampling for the prevalence of HPV, but also for the detection of CIN2+. And this is also a recommendation from the WHO. Now, and it's a big game changer, it's a possibility to have point of care device. It means that you can do the test on site. It takes approximately 1 hour, and you have the 14 HPV genotype. It's very easy to use. You don't need a lot of training. If you are a clinician, you can learn a lot in one afternoon or very few training. This is our approach that we do since now 5 years. This is a 3T for test, triage, and treat. What we do first, we do the counseling. After we do a self-sampling, we do a rapid PCR HPV. And as you know, 80% of them are negative, and you can do reassurance and screening in 5 years. And for those being HPV positive, we do the VIA just to triage those who are positive or those who are negative. If positive, as you are no cytology, as you are no histology, we do immediate treatment. At the beginning, we use the YARC criteria. And as you know, YARC criteria for VIA is coming from the colposcopy. They have worked a lot at the beginning of 2000s, the criteria of VIA, but it's quite similar to colposcopy. Is no acetal white or faint acetal white is negative, and if it is dense and opaque dull white, it is positive. And for example, for this case, it's very easy, okay? You don't need a colposcope. You see native and after VIA, and you see this is positive and this patient needs a therapy. But most of the time it is like this. This is smartphone picture here. Most of the time this is like this. Is that positive or is that negative? But you have to decide. You know, you don't have time to do a biopsy. You have to decide to treat or not to treat. And we do 2 large studies with people having a large experience in VIA. And we know we had this result because all women having an HPV positive had the biopsy, a cytology, and another cervical brushing, which was the gold standard, the reference standard. And what we see is that finally we lose a lot of patients and we don't intensify the CIN2 plus. And what we change at this time, we change 2 things. The first thing that we change, we do what we call relaxed YARC criteria. And we say any acetal white area should be considered as positive. And only if you have no whitening, you consider this is negative. We do this is the first thing that we do to improve our VI. And the second thing that we do, we learn, because it's this time in Zambia, they have introduced in the program a camera, and they use camera to do the photo of the cervix. And the advantage of this is that they have the possibility at the end of this week to review all cases and to discuss with the staff all cases. This is quite a quality control and to reduce the subjectivity of the exam. And after, we see that using smartphone we can have very good picture. One was a big advantage of the smartphone. This is very easy to use. It's transportable. You don't need a front lamp, because if you are using the camera, you have problem because you have problem with the light, and you have problem with the focus, because the focus go on the vulva, on the hair, on the vagina. But here with the smartphone, it's easy to have a very clear photo from the cervix. Second advantage, you can swipe from native to VIA to VD if you use VD, and back to native. And it was very useful for our provider. And these 2 things has improved our VIA. Here's a photo of the smartphone. As you see, the quality of the picture, if you have good provider and good photographs, this is good, and you can really say if it is positive or negative. Of course, the quality is not so high than a high definition colposcope, but the quality is acceptable, and is acceptable to say if it is positive or negative. And this is one of our screening room. Here you see you have the device which supports the smartphone and to make the picture. And we have made 2 large studies before the introduction of the smartphone and the change of the VIA. And you see in green, in blue, this is a specificity. In red, this is a sensibility. And you see the sensibility was very, very bad. And our group, we have made a good training for VIA. This is not the problem. And after we changed two things, I mean, introduction of the smartphone and the change of the YAC criteria, we change it. And we have this times a good sensibility. Okay, we lose a lot of with the specificity, but we have this times a good sensitivity. And because the privilege is to have a good sensitivity, even if you have a bad specificity, of course, better is to have a good specificity, but because the treatment is thermoablation, and thermoablation has very few side effects, probably, of course, less than conization, LEDs, or LEAP. And now we are using in our daily practice, the group working in Cameroon are using the smartphone for all patients before acetic acid, after acetic acid, and Lugol. And this allows to monitor the performance. This is a quality of assurance of VIA, like a colposcopy. We determine the VIA positive, suspicious of cancer, why they have a suspicion of cancer. We can discuss in group why they have suspicious of cancer or not. And the number of CIN2, and when we have the pathology, we can review with the group those who are positive and those who are negative. The take-home message is cellular phone produces a high-resolution image of good quality for a rear having no colposcope. Of course, it's not so good as colposcope, but it's practice, portable, easy to use, inexpensive, and it's aligned with the WHO efforts towards elimination of cervical cancer. And now we have emerging technology using AI to assist frontline provider, and the use of smartphone will be, I think, more important in the next future. I would like to thank you for your attention.
Great lesson as always. Thank you, dear Patrick. And I think that we have some questions at the end of the session. Thank you.
Thank you.
Now, my pleasure and honor to introduce Professor André Boris Kind, the Deputy Head of the Gynecological Hospital in Basel, Switzerland, and take care from 2020 of the organization and the execution of certified colposcopy courses in Tanzania. So important, the courses, train the trainers. Thank you, and we are waiting to listen to your lecture.
Thank you very much, Mario, and thank you very much for the organizing committee to giving me the chance to present one of our collaborations. I would like to talk about a very practical approach of improving cervical cancer screening by colposcopy trainings. Okay, so I have no conflicts of interest in this talk. So our courses take place in Tanzania in a small town called Ifakara, which is around 8 hours by car from Dar es Salaam. And before I go into the details of the courses, I would like to give you some background on Tanzania and cervical cancer. So Tanzania has one of the highest cervical cancer incidence rates in the world, with more than 60 per 100,000, translating into more than 10,000 new cases per year and 6,500 women dying of this disease each year. So we have talked a lot about today about the WHO targets for cervical cancer. So how is Tanzania performing here? So Tanzania has a vaccination program for girls only since 2018. And in 2023, there was an estimated 80% of girls vaccinated with the first dose, or it's a single dose program now, by the age of 15. So we are not doing too bad here. There's a national screening and treatment program. So you can screen either by cytology, by HPV testing, or VIA. However, due to financial constraints, it's basically only VIA which is done, and some HPV screening pilots are starting now. In the screening age between 30 and 65, estimated 15% of women have ever been screened. So we are very far away from the 70% we are aiming for, and 30% of the ones who have been screened do not receive any treatment despite having positive lesions in VIA. Now, the courses we do are a collaboration of a lot of Tanzanian, Swiss, and German hospitals, institutions, and organizations. And the courses are led by Dr. Sister Macunia from the St. Francis Referral Hospital in Ifakara, and the clinical part is organized by Irene Kasiga and Dorcas Msaba. It's a 7-day course. There's a theoretical part, a practical part, and at the end, a written examination. And this course is accredited by the Medical Council of Tanganyika, which is the regulatory authority in Tanzania for medical education and training, and awarded with the maximum of possible CME points. As this course is accredited, participants have to pay for it. It's the only accredited colposcopy course in Tanzania. So the participants are coming from all over Tanzania, and some of them are traveling 2 days to come down to Ifakara to participate in our course. We have done up to now 6 courses. The first course was only online due to COVID-19. And in the 5 courses we've done in presence, we have trained up to now 115 staff, of which 1/3 were nurses and 2/3 physicians, of which were 34 obstetrical and gynecological specialists. So the theoretical part is 3 days long, and it's basically the same content we have in the basic and advanced colposcopy courses we do in Switzerland. So we are talking about the basics, so the epidemiology and biology of HPV, about vaccination, cervical cancer. And then we talk about screening strategies in different settings. Of course, about colposcopy, the basics, about squamous and glandular lesions, about the biopsies and communication with patients. And then a very important part, and Mario will talk about this later, is that doing colposcopy doesn't mean that you only look at the cervix. You have to look at the whole anogenital region, and that's why we are also talking about the vulva, the vagina, and the anal region, and also about infection, because this is also what we should look into when we're doing colposcopies. And of course, we talk about the management of abnormal findings. So our speakers are coming from Tanzania, Switzerland, and Germany. So we have Tanzanian cervical cancer screening providers, obstetricians and gynecologists, a public health specialist, a pathologist, and a biologist. There are a lot of talks, but equally there are a lot of group works and discussions. And you can see here, or not. You can see here some presenters of group discussions. So these courses are always very lively. The practical part is a 4-day part. We do a real life screening in an outreach setting. So we go with the whole course to the villages and companies in the surrounding areas. And there we do screening in a single visit approach. So we do on the same day at the same spot HPV screening by self-sampling. The HPV positive women receive a colposcopy, and the colposcopy positive women the treatment. And we do all this within a study setting to be able to evaluate what we are doing. I would like to show you now the practical part we did in February this year as an example. And weeks before we came here for the actual screening, the activities started there. The medical staff of the factories went to the factory into the fields to sensitize the workers on cervical cancer, HPV, and the possibilities of screening. And they motivated more than 600 women to potentially participate. In the end, we screened 422 women in these 4 days. So the women came, were registered, and took their vaginal sampling. And then the vaginal self-samplers were analyzed. So we used the C-Gen-LPlex test, and we built up a PCR lab in the field on the spot. And it takes around 4 hours between the vaginal self-sampling and the result. And the HPV positive women received the colposcopy. The ones with minor changes, a thermoablation, and the ones with major changes or who are not eligible for thermoablation, a LEAP. So this is part of the algorithm we use. I don't want to go into the details because of time, but it's in line with the Tanzanian guidelines and based on the WHO recommendations. So of the 422 HPV testings we did 112 colposcopies. So now these are the colposcopies the course participants do themselves on the ground in small groups under supervision. Then we have done 13 thermal ablation, 13 LEAP, and 2 patients were diagnosed with cervical cancer. We use digital colposcopes, and the advantage is that it's really a brilliant picture with a very good lighting. And the big advantage is, again, that you can mirror the exam live on screens so that not all the course participants have to gather between the legs of women, but can stand on the side and follow the exam together with the woman if she wants to. So as I told you, we are not looking only at the cervix, we also teach how to look at the vulva. On the left picture, you have a woman with a lichen sclerosis. She additionally has a vitiligo. And on the middle and on the right picture, you have patients with severe dysplastic lesions. The same here in the perianal region. We don't do high resolution anoscopy in our courses. And we look at the vagina and look at infection. And I think you see here the excellent quality of these pictures. The left woman had gonococcal infection. And then we talk about the transformation zone, and Vesna, Mihaela have already explained this. It's very interesting to see that the squamocolumnar junction, to realize where it is and to recognize, it's even for the gynecological specialists very difficult in the beginning. But without being able to identify this zone, you can't do a colposcopy and you can't do a VIA. So it's very important, and we train this on pictures, in group works, in discussions, and of course in our live sessions, so that at the end everybody is able to identify this zone. And of course we talk about dysplastic lesions. We also talk about challenges and limitations in colposcopy. And in our population, in the setting we are working in, up to 50% of women have a cervicitis, mainly with trichomonas. This is a problem because the colposcopy might be false positive, there might be an overtreatment, and there might be complications after treatment. And this is also a problem for the artificial intelligence in the future. An even bigger problem is that up to 50% in our population have a transformation zone type 3. And we learned already from Vesna and Mihaela what this means. It means that we have HPV positive women, which we don't know whether if they really have a dysplastic lesion. So we end up in treating them, at least the HPV 16 and 18 positives, like it's recommended by the most guidelines. And we have a severe number of overtreated women here, because the prevalence in our cohort is between 25 and 30% for HPV positivity. So we urgently need a method of triage here in these women, as we do not have cytology and pathology. We train, of course, thermoablation and LEAP on models, like you can see here. And some course participants can do thermoablation in patients under supervision. And LEAP we demonstrate with our Tanzanian providers live in the courses. So in these courses, the participants not only learn doing colposcopies, they also see how the organization and the equipment and the whole process is working. And I think that's also a very important part. They also see how the HPV testing, including the self-sampling and the lab work works. So the courses are always a lot of fun. People are laughing a lot. Everybody is enjoying, and I think that's a very important part of work and a very important part of the success of these courses. And people are building networks. I've showed you that people are coming from all over Tanzania to join the courses. So they have networks and they have WhatsApp groups and discuss afterwards complicated cases. And I think this is something you can never, ever reach by doing online courses only. So thank you very much to all collaborators, especially to my dear friends from Tanzania, to Brigitte Frey from Switzerland and Andreas Kaufmann from Germany. Thanks to all funders, and thank you to all of you for listening.
Thank you to you, dear Andre, for this lesson and for taking care also for the vulvar and perianal area that most of the time are missed by the colposcopy. Thank you. Because I think that the HPV-related vulvar intraepithelial neoplasia and vulvar cancer are of concern in this population. So it's very important, your approach. Thank you. Now I think that is Mario again. Well, and as Andre just told you, we are going to talk about vulvar cervical examination. Click on the board. Well, why we should teach it? This is the increasing of vulvar cancer incidence during the years. And we see in Italy that stress that the younger cohorts are at higher risk of increasing the incidence of vulvar cancer. So it is important that the vulvar cancer is the cancer that has the longest diagnostic delay. It's important the early diagnosis. Because this delay, because it's a rare disease, because of inadequate training. So we put together three different groups: the resident, the physician and nurses involved in cervical cancer screening procedures, and the women. Starting from the residents, a study of last year in Italy showed that at the 5th years of residency, 12% of residents have never dealt with lower genital tract pathology, but most of all, almost half of them were not able to diagnose and treat lower genital tract pathologies, with the exception of initial evaluation in ER. So a sad news. Well, and women, another study in Italy, we noticed that vulvar sex examination is still an uncommon practice, but it could lead to early diagnosis of vulvar squamous cell carcinoma, differentiated of HPV-related VIN or lichen sclerosus. And we see that less than 25% of the women know about the vulvar self-examination. So most of them would like to have more information, and we are here for that, because physicians and nurses involved in cervical cancer screening procedures are, as Andre just told you, are so important. Because in this study, always in Italy, all the physicians replied to our survey that they pay attention to the vulvar inspection before taking the purple of HPV test or to perform the cervical colposcopy. But it's not true. They are liars, because the incidence of intraepithelial and invasive vulvar neoplasia doesn't show a downward trend. And so you can download with this QR code our recent paper with the last name of our chair, Murat Kultekin, and we worked with 4 different societies: the European Society of Gynecological Oncology, the International Society for the Study of Vulvovaginal Disease, the European College for the Study of Vulvar Disease, and the European Federation of Colposcopy, stressing that there was consensus statement that all the healthcare providers dealing with cervical cancer screening are recommended to take history of the vulvar symptom, to inspect the skin of the vulvar region, to inspect the vulvar vestibule, and to report any abnormal finding. The most important is that in patient sent to colposcopy with positive screening test, HPV or PAP test, positive test, increasing attention for any abnormal finding, in particular between the inner part of the labia majora, where VHC, HPV related, the pre-invasive vulvar intraepithelial lesion is HPV related is more frequent. But it's important to explain and recommend how to practice vulvar self-examination and discuss with all patients treated for cervical or vaginal intraepithelial neoplasia or cancer the increased risk for intraepithelial or invasive vulvar neoplasia. We have to take just a couple of minutes to explain this. It's very important. It's so important because the concern of infected partner, the sexual dysfunction, the anxiety of revealing their body after treatment. So we have to prevent disfiguring treatment, because we know that cure is important, but knowledge and prevention is even more important. This is another QR code, and thanks to the ESGO and the Engage organization, we are so proud to share this vulvar self-examination leaflet. And from yesterday, we have the 15 different languages in Arabic too, and you can download it in, of course, 15 different languages. How to follow the vulvar self-examination? Before of all, to explain how is made the vulva, because most of the woman doesn't know, and explain the labia majora, minor, the clitoris, the clitoral wood. We have just seen from the Andre picture that some cases of lichen sclerosus can be diagnosed earlier and reduce the risk of HPV independent pre-invasive and invasive lesion. And performing vulvar self-examination is the essential way to detect any change or abnormality. Who should perform vulvar self-examination? All the women. How often? Preferably every 3 months, every season, or of course, anytime when experience vulvar itching or pain during sex, or when detects vulvar lumps or thickening of the skin. What we need? Clean hands, small mirror, good lighting, and private space. Privacy, please. The most important question from the woman: what should I look for? Look for the following sign. What is normal? The physician, the nurse, the midwife can explain what is the normal structure of the vulva, and then the patient will be able to look out for the new changing lumps, bumps, sores, redness, swelling, irritation, of course bleeding, but also changes in color or texture of the skin. How to do? 4 important steps: examine it, palpate, note, and report. examination, starting from a general examination and then detailed examination beginning at the 12 o'clock position, focusing on the clitoris, then the labia majora, the labia minora, the clitoris, and proceed with the examination of the vestibule. Palpation, palpate the area for abnormalities. Note your finding. In our study, most of the patients that found some changes in their vulvar skin didn't report to their physician or nurses. So it's important to note and report following up with your healthcare provider. Early detection is the code, the final sentence of our leaflet. So do not hesitate to reach out your healthcare provider for any concern, because it's not a woman problem, it is everyone problem. Healthcare professionals should learn to how teach vulvar sex examination, establishing a supportive environment to provide educational materials, and the engage and the school already prepared this material. We can download and share with your patient, with your friends, and demonstrate this technique to guide the patient to the practice and reinforce the importance of regular examination, because early detection saves lives. To avoid that from lichen sclerosus, for example, it develops invasive squamous cell carcinoma. And so promoting awareness is an important first step. Well, I save again 5 minutes. Okay. And then I will give a look to the question. We are in time to listen to the final lesson of this session, colposcopy scenario focusing on Africa. And again, it's a pleasure and honor to present Professor Egemen from the National Cancer Institute. We know that she is the light in the darkness of the numbers. Numbers are nothing without her help. Thank you again, Didem, and the stage is yours. Thank you.
Thank you so much, Dr. Preti, for this nice introduction. This is a colposcopy session, but I will generally talk about visual evaluation through AI, and is it a possibility for Africa? Let me click on the screen. Okay. So first, I will go through our approach and then generally talk about whether AI is a solution for visual screening in low resource settings. So we have a PAVE consortium that we mentioned in the previous session, and we conducted this study in 9 countries in South America, Africa. So this strategy, this screening strategy, starts with HPV self-sampling. Everyone coming into the clinic takes their own sample, and then we evaluate these samples for HPV, and our test gives 13 types in 4 hierarchical levels. And if they're HPV negative, they are reassured, but if they're HPV positive, through a handheld device, we take the image after acetic acid application. And our algorithm will evaluate the image to give one of the 3 test results, either normal, indeterminate, or severe. And then our aim is to create the risk profiles of the individuals by combining these 2 biomarkers, HPV and visual, and define who needs treatment most. And actually, the device we used in this study, it also has the treatment probes. So the same device can be used to ablate for treatment. So I showed this result in the previous session, but I just want to repeat that these results are from our external validation study. So we created our AI algorithm on 5 different studies that we already have images collected from. And this study, this PAVE consortium, was specifically for externally validating our AI algorithm. But since we changed the image capture device, we incorporated 40 individuals' data from each one of these classes and retrained the algorithm. And these results are from the retrained algorithm. So the 7.2% precancer risk in HPV positive can be stratified through 3% to 19% with HPV test only. And with only the visual test, we can still stratify that 7% risk all the way from 5% to 13%. But the best risk stratification is obtained when we combine these two strategies. With this combination of this visual test, AI-based visual test, and HPV genotyping test, that 7.2% risk increases to 27% if we know that individuals are infected with 16 and their cervix looks really severe. And then the risk goes all the way up to 1% if they are infected with the least risky HPV types and their cervix looks normal. So how can we trust these AI models? These are black box models and they create some results, but how can we trust them? Is it really valid? So we need to actually validate the performance of these AI algorithms and what metrics are important for the validation. So we have been working on this AI project many years, and I joined this group since 2020, and I've been working on AI for 5 years. So I will present you the most important metrics to validate these AI algorithms. So these are reproducibility of test results, external validation, consistency across different settings, and risk stratification. So I'll go one by one. Let's start with the reproducibility of test results. What do we mean by that? So when we, in our studies, we always collect multiple images from the same individual at the same visit and with a very short time interval, like in a click fashion. When our algorithm evaluates these images, it should give the same result for the same individual. But in our early studies, we were only working on 2-class classification. So we were asking the algorithm to identify each images as either normal or precancer cancer. And here what you're seeing is this is the x-axis is the first image score. The y-axis is the second image from the same individual. And when we plot them, we see a sort of like a butterfly shape. This middle part is the problematic area. What this means is when we look at these individuals, their first image might be classified as normal, but their second image is precancer or vice versa. So that is very unacceptable for a clinical test when we are testing the same device, the same test on the same individual with repeated measures. It should give the same result. So that's why we moved from 2-class classification to 3-class classification, since there is an obvious third class at the middle. And by implementing some technical methods, we were able to increase the repeatability. So the repeatability of the test is the most important factor. So to be a medical device, a visual evaluation, it must be reproducible. And what we mean by reproducible, when we use the same equipment on the same sample, same person, same time, it should give the same results. And if we repeat the sample with the same equipment on the same person at the same time, it should give the same result. And then if we also repeat this test in a short time interval on the same person, we should get the same result. And also in general, if we are using the same kind of equipment, like the same brand of cell phone or same brand of digital camera across different studies, we should be able to get similar results from similar populations. Also, different location, different time, different operator, different hardware and software, that shouldn't be changing the results dramatically. Like, we should be obtaining similar outcomes. So this is the most important first validation metric. And then the second one is the external validation. This is very critical because when you look at most of the AI applications, they use one big data set and divide that into 3 pieces. And with the first 2, they train an algorithm and test the algorithm performance on the third part. But most of the time, this is a too good to be real result. And this is an internal validation. So that's why we keep mentioning that external validation is the must. So if you want to make sure that an AI algorithm will perform well, it should be tested on other external data sets. So in our example, we used 5 different studies to train our algorithm, and our PAVE consortium is our external validation study, and the results I showed you is from our external study. We still incorporated a small amount of data since we changed the device. I will mention that point in my second metric. So, but still, we have around 10,000 individuals in our training set, and we only incorporated 40 individuals data from each class, and it still performs the same amount, we can still obtain the same performance when we conduct our study in our external PAVE consortium cohort. So these are our very early experiment results with the binary model, and my team did the same mistake. If you look at these, I proceeded too much. Okay, so if you look at these publications, these results are from the internal test sets, and you obtain a very good AUC around 0.9. And in general, when you look at the literature, there are like AI applications with like 0.9 AUC. These are like too good to be results. They should be validated on external data to make sure the AI algorithm is applicable to an external environment. Because what we see with those experiments, like when we actually tested these models on a completely different data set, what we see is this is a similar graph that I showed you before, image 1 versus image 2. Regardless of the ground truth, most of the patients are classified as normal. So the performance completely degraded. So that's why external validation is very important to make sure that the AI algorithm can still have high performance on your new data set. So the third point is consistency across different settings. So this is still related to external validation. So whenever something changes in your data environment, there should be like a continuous monitoring of these algorithms. The most important factor is image capture device. According to our experience, when you change the image capture device, like if you use a different device than the ones that your algorithm is trained on, your algorithm will completely fail. So to be able to actually maintain a similar performance, we need retraining in our case with only a small subset from the new data set. Also, we tested our algorithm on different populations, HIV positive, HIV negative. Our original algorithm was only trained on HIV negative individuals, but when we tested it on HIV positive individuals, we were still able to obtain the same high performance because our guess is HIV positive individuals, when they have precancer, their cervix look really severe, more severe than HIV negative individuals. So we still have a good performance on different populations. And also we tested changing the geography, like keeping the same camera type. When we change the geographic region, we still get the same performance from our algorithm. So in general, when you want to test these AI algorithms, when you want to validate and make sure they're applicable, there should be a continuous monitoring whenever anything changes in your data environment. And the last thing is, it should create risk stratification, otherwise it's not a useful test. So it should be able to stratify high-risk individuals from low-risk individuals. As I showed you in my very first slides, our algorithm, this is our external validation, we were able to obtain very high risks, especially when we combine this AI-based visual test with HPV genotyping results. So to sum up, in general, AI models, they can offer significant promise to enhance the cervical cancer screening, especially in low resource settings without needing a biopsy. But AI models, at the end, they are a biomarker, and they should also follow general epidemiologic and biostatistical principles. The most important factors that needs to be checked are reproducibility. When you implement this test on the repeated images, do you still get the same results? External validation. So it's not only enough to validate the algorithm on the same data set, like the part of the data set that the algorithm is trained on. You need to go and test it on other data sets, external data sets, to make sure the generalizability of these algorithms. And whenever something changes in this data environment, you need to be careful and continuously monitor whether, like the most important one is the image capture device that completely degrades the performance. It should be monitored on different populations, different geographical regions, but in our experience, they don't change the performance. So we still were able to obtain high performance. And also it should create risk stratification to be a useful test for your screening program. So thank you so much. I don't know, we have time for questions.
Yes, thank you, because your lecture about reproducibility, external validation, risk stratification is amazing as always. Thank you so much.
Thank you.
Well, we are better than in time, and I asked to our chair, dear Murat, if we can go on with the next session, but I asked to all the speakers of the session to turn on the camera so we can have a screenshot of our session. Thank you. Please, dear Mihaela, Vesna, Patrick, Andre. Well, and we ask Susanna to take a picture of us. So our fourth section, colposcopy scenarios focused on Africa, will be successful. Thank you again. And